Shall we start, sir?
Yes,
I think so.
I think yes.
Yeah,
Yes.
I welcome all the esteemed guest speakers and panelists. And society has taken this initiative to cover all the spectrum of cerebrovascular pathologies and to start from basics so that it can help a better understanding for young neurosurgeons so that they can learn, they can start their surgery on their own and simultaneously covering basic aspects, complications, and advanced things also. So I would invite our first speaker, Dr. Jayanam. He will speak on anatomy of anterior communicating artery. Dr. Jayanam.
Yeah, thank you, Dr. Anil. Good evening, everyone, and thank you for inviting me to be a part of this webinar and contribute to it. Today I'm covering a very basic topic, the anatomy of the anterior communicating artery, and a little bit about the history of the anterior communicating artery and its nomenclature. The circle of Willis, as you know, was described by Thomas Willis, and the basic purpose of the circle of Willis is to ensure that collateral blood supply occurs at the base of the brain so that both side hemispheres of the brain can be adequately perfused. If anything goes wrong on one side, possibly the collateral circulation or these channels of communication between the blood vessels, between the anterior circulation, that is the ACOM, and between the anterior and posterior circulation, there is a posterior communicating artery, will take over the blood supply. But this is not always the case. Sometimes there may be variations wherein one of the communicating arteries may be smaller in size or maybe aplastic as such. And also the basic purpose of having a circle of Willis at the base of the brain, including the normal sinusoidal curves of the internal carotid artery at the cavernous sinus, is only to dissipate the energy or the pressure that the blood comes into the brain circulation and to keep this the pressure of perfusion quite uniform throughout the brain. Oh, I'm not able to move my slide forward. Yeah. So this is the maze of the vasculature of the brain, the arteries and the veins. And in this maze, the anterior communicating artery just forms a very minuscule part of the entire brain circulation. And yeah, so this is the basic structure of the anterior cerebral artery as a whole. You can see the anterior cerebral artery arises as a branch of the internal cerebral artery and moves medially from the branch point of the internal cerebral artery. And this segment of the anterior cerebral artery between the anterior communicating artery and the origin at the ICA bifurcation is called the A1 segment. The anterior communicating artery demarcates the differentiation between the A1 segment and the A2 segment. The A2 segment, as you know, is from the ACOM A1 junction to the junction between the rostrum and the genu of the corpus callosum, which is around here. And the A3 follows the genu of the corpus callosum and ends at the rostral part of the body of the corpus callosum. A4 and A5 lie on the body of the corpus callosum and is divided by a plane through the coronal suture. So you can see the position of the anterior communicating artery that connects the junction between the A1 and A2 on either side. Now, this is again the nomenclature. The A1 is the pre-communicating or before the anterior communicating artery. The ACOM is an integral part of the anterior cerebral circulation, which connects both sides of the anterior cerebral arteries. The A2, that is the segment between the A1 ACOM junction and the rostrum of the genu of the corpus callosum, that is the A2 segment. This part of the anterior cerebral artery is actually very important in the sense that many of the perforators arise from this region, the A1 perforators, that is a continuation of the ICA bifurcation perforators. And one of the most important perforators in this region is the recurrent artery of Hubner. And this arises from the A2 in almost 78% of the cases, and A1 in 14% of the cases, and ACOM directly from the ACOM in 8% of the cases. It's very rare. And the length is approximately 4 millimeters, and the orbitofrontal artery is at around 5 millimeters, and the frontopolar artery is also an important branch that arises from this segment. and the anterior inferior frontal artery is also a very small branch. Now, this is the view from below. You can see, sorry, from the front, and you can see the optic chiasm and the optic nerves that has played a part. The space between the optic nerves is called the intraoptic space, and you can see the disposition of the A1 segments that follow the surface of the optic nerve. So, if you have to identify the A1 segment of the anterior cerebral artery, you will have to trace back above the optic nerve. In most of the cases, it lies above the optic nerve. In very few cases, you can have a subchiasmatic A1 or sub-optic nerve A1 segment. And you can see the lie of the anterior communicating artery here that connects the A1s on either side. The anterior communicating artery can be very small, it can be rudimentary, it can be of normal caliber, that is around 1 to 2 millimeters, or it can also be duplicated or have multiple channels of communication, and such anatomical variations will be described further on. You can also see the lie of the recurrent artery of Hubner. The term recurrent because it traces its path backwards along the lie of the A1 to supply to give off important perforators. So that is the reason why it is called recurrent, is because it takes a retro course in comparison to the A1 segment, which is antegrade. Now, there are perforators that arise from the ACOM artery as well. And important relationships of the ACOM artery are, as already mentioned, the vessels around it. And also, the other important relations are the gyrus rectus, that is the one of the gyri on the base of the frontal lobe. You can see the disposition of the olfactory nerves also on either side. One of the key components of dissection towards the anterior communicating artery is the olfactory nerve, because in a full brain, if you have to identify the lie of the A1 segment, you need to dissect in the subfrontal plane, and identification of the optic olfactory nerve is a key component of this dissection, because the olfactory nerve and the optic nerve will lead you to the A1. If you dissect the plane between the olfactory nerve and the optic nerve, it will definitely lead you to the A1 and further on onto the ACOM. Now, the ACOM artery, as I said, is the intercommunicating artery between the anterior cerebral arteries. Proximal to it is the A1 segment, distal to it is the A2 segment, and the length of the ACOM can be around 2 to 3 millimeters, and the diameter is between 0.2 to 3 millimeters. That is, it can be very small and rudimentary 0.2 millimeters, or it can be quite big as well, 3 to 4 3 millimeters as such. The basic purpose of how and why it will be of a certain caliber is depending on whether it will take the circulation from one side across to the other. If the circulation of one A2 is the supply from of one A2 is quite good from one of the A1s, and similarly the other A1 is supplying the other side A2, then the ACOM may not have a significant function. So if that is the case, the ACOM can be rudimentary. But if the ACOM communicates and carries blood from one side of the ACA to both A2s, then the ACOM can be of significant caliber. Also note that it can be absent in a very small proportion of cases. Perforators arise from the ACOM, but the main point of concern here is that the ACOM perforators usually arise from the posterior-superior aspect of the anterior communicating artery. Perforators very rarely arise from the rest of the surfaces, but most commonly they arise from the posterior-superior surface. These have surgical relevance because anterior communicating arteries also, their projection will decide how much you have to dissect these perforators off the posterior surface of the aneurysm. If the aneurysm is projecting superiorly or posterior-superiorly, these perforators will be densely adherent to the posterior surface of the aneurysm. So in the process of dissection of the aneurysm, there is a chance that these perforators can be injured. So the number of perforators described is from the ACOM 1 to 4, from the A1 4 to 8, and from the proximal 0 to 10. So these are variable. Some of them may be present, some of them may not be present. So these perforators are quite variable in number. Now this is the 3D representation of the direction of origin of the perforators. You can see that the majority of the perforators are posterior-superior, and that is accounting for around 54 and 36% of the entire perforators. Inferior perforators and anterior perforators are very small. Some of these perforators will supply the optic nerve and optic chiasm region, and these are very small submillimeter blood vessels. This is a graphic representation of the lie of the anterior communicating artery. The anterior communicating artery, one should remember that it can be disposed in any plane with respect to the cranium. It can be horizontal, parallel to the floor when in standing position. It can be anteroposterior. It can be also have a supero-inferior disposition, and the basis for this lie is actually in the development of the blood vessels. When the development of these blood vessels comes in, the differential development of A1s and the dominance of circulation, all these determine the final lie of the anterior communicating artery within the cranium. Also of importance is the lie of the A1 segments and also the dominance of the A1 segments. If one of the A1 segment is very dominant, that will decide how the ACOM will lie with respect to the optic nerves and optic chiasm. So the disposition of the ACOM is of prime importance in ACOM artery aneurysm surgery, because the ACOM lie will sometimes decide which side of the patient should you approach this aneurysm from. There are various other factors. One may be the dominance of the A1 and also the fork of the A2s, that is the lie of the A2s with respect to the ACOM. One of them can be anterior, one of them can be posterior. So that is the fork of the A2 that I will describe soon. Now, these are the disposition of the perforators. You can see the perforators arise from the posterior-superior surface of the ACOM. You can see the A2s on appearing towards you, and what you can see is the superior surface of the ACOM, where the label is the ACOM, and you can see the perforators usually arise from the posterior-superior surface of the ACOM artery. Now, there are various cisterns that are associated with the ACOM. These are the optic chiasm cisterns, lamina terminal cistern, also the structures hypothalamus, fornix, corpus callosum, the septal region. The perforators arising from the anterior communicating artery will supply the septum, the hypothalamus, the fornix, and the anterior cingulum. So these are vital perforators that are important in the prime functions of the hypothalamus, the consciousness, and memory as well. Now, this is the lie of the cisterns that I was mentioning. You can see that these blood vessels are enclosed in cisterns, and this is the lamina terminalis cistern, which holds the anterior communicating artery. You can see the lamina terminalis cistern encasing the anterior communicating artery. So these cisterns are important, and the disposition of the cisterns is also quite important in times of dissection, because it is the arachnoid planes that have to be cut sharply during dissection to expose these arteries and the anterior communicating artery. And one should have thorough knowledge about these cisterns, because these are the cisterns that need to be cut open one after the other to release CSF in case of encountering full brain, especially during subarachnoid hemorrhage and aneurysm surgery. Now, these are normal variations of the ACOM that have been described. Duplication of the ACOM can be either complete as shown in the left panel, or can be incomplete as shown in the right panel. And there are other variations of the ACOM that one should always be wary about and should be aware. The azygos A2, wherein there is no anterior communicating artery, because both the A1s will connect to a single artery called the azygos artery, and the azygos A2 will supply both the hemispheres with small blood vessels arising, the branches arising from the azygos A2. And azygos A2 typically is very commonly associated with aneurysm, because the flow into the azygos A2 is from both sides, and hence it's very hyperdynamic, and any weak point in the blood vessel wall can lead to aneurysm development. It's very common to see aneurysms developing in azygos A2. Sometimes the triplicate A2 can occur, in which one can be confused which is the ACOM artery. It may be between any of these two, the three branches of the triplicate A2. And sometimes a single A2 may supply both the hemispheres. That is called a bihemispheric A2, wherein the other A2 can be very rudimentary. Hypoplastic A1 is very common, and it determines the side of dominance of the anterior circulation, and it also decides sometimes where an aneurysm will develop and what direction it will project. The normal, if one of the A1s is hyperplastic, it means that the normal A1 has to overwork to supply both hemispheres of the brain. This overworking means it will be of a higher caliber and will supply both the A2s. The opposite A2 will supply will be across the ACOM. So ACOM will also be of a very big caliber. And the maximum stress that develops in such situations is at the A1 A2 junction, which can lead to the development of an aneurysm either in the ACOM or at the A1 A2 junction. So this is how it occurs. You can see this is a typical aneurysm that is developed at an A1, A2 junction. The opposite A1, that is the right A1, is hypoplastic. The left A1 is dominant here, and you can see that the stress dissipation has caused an aneurysm to develop. So you have to understand the disposition of the A1 and the line of lie of the aneurysm also in this situation. The lie of the aneurysm will usually be in the axis of the A1 segment, because the aneurysms usually develop in a line where blood would have flowed had it not encountered an obstruction at that point. So the lie of the A1 will usually determine the axis of the aneurysm. Now, why do aneurysms develop on the ACOM? As I said, it's determined by the lie of the A1. It's also decided by the hypoplastic or asymmetric A1s, because if one of the A1s is dominant, it can lead to a hyperdynamic circulation on that side, and that side will overwork, and any small defect in the vessel wall can lead to the development of an aneurysm. Also, other factors have been considered. There is smaller angle between the A1 and an A2 segment of the anterior cerebral artery. This can lead to an aneurysm development. A higher angle between the A1 and A2 means that the blood flow will be quite streamlined, and there will be no hemodynamic stress occurring at the A1 A2 junction or in the region of the ACOM that can lead to development of aneurysms. And anatomical variations, as I said, like the azygos A2 can lead to development of aneurysms. Now, this is the projections of the aneurysm. You can see the various projections that are described. You have to see perfectly in the sagittal plane, but you should also take into consideration the lie of the ACOM, as I have said previously. The lie of the ACOM can be in any direction. It can be perfectly in the mediolateral axis, or it can be disposed in a supra-inferior axis or in an anteroposterior axis as well. So based on multiple factors, you need to decide what is the lie of the aneurysm, and the lie of the aneurysm will decide whether the aneurysm is going to be free of perforators. So an antero-inferior or a purely anteriorly projecting ACOM aneurysm will usually be free of perforators, and we can be directly clipped without having to dissect the perforators. But the problem with the antero-inferior projecting aneurysms is that some of these aneurysms can be densely adherent to the dura or the basifrontal region or on the optic nerve. So you may sometimes inadvertently cause its rupture by a retraction of the frontal lobe. So one has to be wary of that particular aspect. By and large, most of the aneurysms are superiorly projecting or posterior superiorly projecting, and these will have to be carefully dissected off the perforators, and it's very vital to preserve these perforators. And in such situations, one should go in for a temporary clipping to dissect the perforators carefully off the posterior surface of the aneurysm. Now, this is A2 fork. An open A2 plane is defined as the A2 of the approach side. That is, you decide the side of the approach to an ACOM aneurysm, and you see that the A2 of that side is located more posteriorly than the contralateral A2. So in the picture that is depicted in the right panel, the A1 is quite dominant on that side and is usually the side of approach. The side of approach may also be decided by the projection of the aneurysm. You sometimes may not want to go into the aneurysm dissection fundus first. So it's better to take good control of the proximal and distal circulation before one gets into an aneurysm dissection. So in this situation, if you are choosing to approach from the side of the dominant A1, you can see that the ipsilateral A2 is disposed posteriorly compared to the opposite A2 with respect to the aneurysm. So the aneurysm lies in the open fork of A2. But had you approached this aneurysm from the opposite side, the disposition will be just the opposite. The ipsilateral A2, if you're approaching from the opposite side, would be anteriorly disposed, and that would mean that it's a closed fork. As in this situation, you can see that the white arrow marks the A1, which will be the side of approach in this situation. And you can see the ipsilateral A2, it takes a antero-inferior curve initially and then disposes itself anterior and slightly to medial to the aneurysm fundus, but it is actually anterior to the ACOM, and the other A2 is lying posterior to the ACOM. So this is the closed fork of A2. So this is the closed fork of A2. So these aspects of open fork and closed fork have been considered for deciding the approach of aneurysm towards ACOM aneurysms. And these are multiple variations of the circular Willis with respect to the ACOM. So a type 1 or ipsilateral flow means that the ICA will supply the A1 on that side, and the A1 will supply the A2 of that particular side. On the opposite side of the same patient, as seen in figure A here, the opposite side is again taken care of by the ICA on the opposite side. The A1 on the opposite side will fill the A2 of the other side. So in such situations, the ACOM may not have much of a role to play unless one of the sides flow is compromised. So the ACOM artery in such situations is not of significant caliber. It may be of a medium caliber, maybe around 1 to 1.5 millimeters. Now, type 2 circulation or bilateral flow is the commonest type of circulation you encounter in aneurysms because one of the A1s is hypoplastic. You can see in this situation, one of the A1s is hypoplastic and the brunt of the hemodynamics is suffered by the opposite A1 because this has to supply both the A2s, and this will lead to a hyperdynamic circulation, and the commonest site of aneurysm occurrence in the anterior circulation will be the anterior communicating artery. Okay. Now, the gyrus rectus, as I said, is an important landmark here because one needs to know the disposition of the gyrus rectus and where exactly we need to resect the gyrus rectus if you are going through a pterional approach to an anterior communicating artery aneurysm. If you are coming via the interhemispheric approach, then the chances that you can preserve the gyrus rectus are very high because you will be splitting the lobes of the frontal lobes to reach the anterior communicating artery region, and the gyrus rectus can be preserved. But if the commonly used approach of pterional approach is used, in that case, one will be tracing the A1 that is marked as 2 here in this figure. And once you reach the that particular region, the problem that occurs is that you have to take control of the all 4 arteries of forming the anterior communicating artery complex, that is both the A1s and both the A2s. And that would be the best situation to get a proper control of the aneurysm before it is being clipped. So in such situations, you may have to resect the gyrus rectus. The reason is that you have to release the H configuration of the ACOM complex from the retraction. So if you suck the gyrus rectus and release the pia that others to the H complex, then the retraction of the frontal lobe can be done much safer, especially in the case of inferiorly or anteriorly projecting aneurysms. You need to be very careful about resection. So to take off the pressure of resection from the H complex of the ACOM, one needs to resect or suck off the gyrus rectus a little bit around just below where the mark 6 is here. And in such situations, you can preserve the orbitofrontal branch, which is marked as 6 here. And you can work between the branches of the orbitofrontal to get adequate resection of the gyrus rectus for a safe ACOM artery aneurysm clipping. Thank you very much. Dr. Anand.
Anil, unmute yourself, please.
Thank you very much, sir, for wonderful talk on anatomy and covering all the aspects and giving insight into basic anatomy and how to approach and what are the various aspects of perforators. Any question, please?
There is, there is a question raised by Dr. Pradipta that perforators from the ACOM, the origin. So what we have studied from Yassergil book also, I think they mention is the arise from the posterior inferior surface of the ACOM. So what is your opinion, Janan?
Yeah, I think the relative, I hope I'm audible.
Yeah.
Yeah. So the basic principle that one has to understand is that the majority of the perforators will arise from the posterior and posterior superior surface of the ACOM. The disposition of the peak, the ACOM is such that the relative position of these perforators may be termed as posterior or posterior inferior depending on your perspective, because some of these perforators will dip down a little before they ascend up along the lamina terminalis to reach their destinations. So this is a relative description of posterior inferior and posterior superior. By and large, they are posterior and superior.
Yes.
I welcome Basant Misra, sir. Sir has joined. Sir, can you hear me, sir?
Yeah. I'm just joining. I'm just changing. I will. Yeah, I listened half of it. So please continue. I'm here.
Yes, sir.
Good
Yes,
evening.
sir.
Yeah. Good evening. Yeah.
So, any other question, please? In typing, I don't see any other question. So now we'll move on to our second speaker, Dr. Adesh Srivastav. Please start sharing your screen.
Yeah. Mhm.
So he will cover selection of the approach and basics in relation to aneurysm direction and morphology in ruptured aneurysm.
दिख रहा है ना अनिल?
Yes, sir.
Yes.
Yeah.
Slideshow.
I'll put it on slideshow
Yes. Okay.
to everyone. अरे यार, just a second. Okay. Yeah. So thank you for the team for giving me this opportunity to speak on this topic. Actually, Dr. Janand has now done my made my work very easy, because he has described it so wonderfully with excellent illustrations. So I'll directly switch on to the strategies and the approach one has to take, considering in view the anatomical relationships and the morphology of the aneurysm in case of ruptured ACOM cases. So the talk will be divided basically into three parts. First of all, the patient positioning, then on which side you wish to go, you will decide to go, and how to go about dissection and clipping depending upon the various projections and morphology of the aneurysm. Now, coming to the positioning part, the first and foremost thing to realize over here that in ruptured ACOM aneurysms, often the brain is quite full. And when you have a full brain, one needs as much possible relaxation of the brain as possible. So to ease out the venous outflow, we elevate the head by around between 25 to 35 degrees, as much as your clamps extension allows. Next comes the positioning of the neck, that is the extension and rotation. So the idea is, because the final clipping of the aneurysm or the dissection of the dome will happen in a position where you will be going through a subfrontal corridor. So you want the frontal lobe to fall off from the skull base. Try to minimize the use of retractors for that. So use maximum possible extension, but in a way that your venous drainage is not hampered. And try to keep the line of the sylvian fissure perpendicular to the floor. This helps in keeping the frontal and temporal lobes falling equally in case you have to the initial part of the dissection, if you have to do the Sylvian dissection, so minimal use of retraction can be done. But one has to be equally careful while using extension in case of inferiorly projecting aneurysm, as Dr. Jayanand had very nicely shown pictures as to how an inferiorly projecting aneurysm, the dome can be tethered to the dura or to the optic chiasm, and if a lot of extension has been given, so once the CSF drains and the brain sags, there is a chance that a little bit retraction in that region and the dome may rupture. So a little bit careful about the limit of extension, especially in the inferiorly projecting aneurysms. The second thing, once you have done the positioning, and the second thing to decide as to what would be your side of approach, whether to go from right side or to go from left side. Now, again, Dr. Jayanand had shown a very nice diagram which was showing all the projections in a single image. So we basically now have started deciding on the basis of how is the aneurysm in relation to the A2 forks. If the aneurysm neck and the aneurysm dome is touching, or is it in close proximity to the A2s, that is it's upward projecting, or probably superior anteriorly projecting. So in the upper half of the line, if you draw a line at the level of A1 and it is in the upper half, that is touching the A2s, in that condition, what is important is to one has to get an open fork, because if the fork is not open from the direction which one is approaching, the chances are that we may not be able to see the origin of A2. We may not be able to see whether there are any perforators at that end, and the clipping may become difficult, because you have to go around the ipsilateral A1 in order to put in your clip. So whenever the fork, the A2 fork, the A2s are actually touching, so you have to go from the side where the A2 fork is open. And the other way around, when the aneurysm is not in relation to the A2s and it is inferiorly towards the inferior side, away from the A2s, then we usually decide from the side where the A1 is dominant in most of the cases. The significance of A2 fork can be seen in this image. Those are three images. First, let's concentrate on the first image. The first image is showing the aneurysm, which we are seeing from above. Superiorly, we are seeing in a CT angiogram. And one can appreciate that the aneurysm is projecting anteriorly and superiorly. And the fork here, the left A2 is anterior and the right A2 is posterior in relation to the aneurysm. So in this case, come to the second image, one can see that on a right-sided approach, both the A2s, I'll just put a cursor over here, Control L. Yeah, so the aneurysm is lying in the middle when you see it from the right side, and both the A2s are on the sides. Whereas if you approach this aneurysm from the left side, the other A2, the origin of the A2 will not be seen, and this A2 will come directly in front of your aneurysm. So you will have to go around putting the clip either anteriorly or from this side. Whereas here the two flanges of the clip can be very easily passed from the sides. So that's the significance of A2 fork. And now with the advent and availability, so easy availability of CT angiograms everywhere, I think this concept is the most helpful in deciding your side of craniotomy. The corridors for craniotomy is obviously we use a frontotemporal mini craniotomy. The idea is a combined use of trans-sylvian as well as subfrontal corridor. Now, we usually prefer to use trans-sylvian corridor initially to drain out, to open up the sylvian and get our proximal control. Why to do it first is it helps in draining out CSF slowly. And many a times we have felt that when the brain is full, and the veins are engorged. Initially, if you drain out the CSF subfrontally or from any other side, probably by using your Payne's point for a ventricular tap, then those engorged veins with very little CSF around them, it becomes very difficult to dissect out. Whereas if CSF is there and the CSF is stretching the arachnoid, so it's easier. So initial part, we try to do it through the trans-sylvian dissection, which helps us to reach the to get the proximal control. There's a slide ahead where we will be discussing this. And especially for inferiorly projecting aneurysm, again, the subfrontal corridor can use of subfrontal corridor can lead to sudden rupture if there is inadvertent retraction, and there may be an intraoperative rupture before you have a good proximal control. So maximum amount of work for inferiorly projecting aneurysms, where the dome may be stuck tethered to the dura or the optic chiasm. So we try to do it through the trans-sylvian route to get early proximal control. Now, a word about gyrus rectus resection. Well, it is not required in every case, as Dr. Jayanan told. It is required only for large high-riding aneurysms or aneurysms, especially which are superiorly and posteriorly projecting aneurysms. If one has to decide how much of a gyrus rectus needs to be removed, so the landmarks that we use are obviously you start coagulating the pia and cut it in anteroposterior direction, medial to the olfactory tract, and posteriorly one has to stop where the A1 just enters into the interhemispheric fissure. If one can see over here, this is the A1 where it is entering into the interhemispheric fissure, and this is the posterior limit of our gyrus rectus removal. So the idea is, as Dr. Jayanan very correctly said, we have to remove that tether, because any retraction with that tether on the ACOM complex can lead to its rupture and difficulty in further clipping. The only thing we try is to preserve the pia over the dome. Preserving the pia over dome, probably in a ruptured aneurysms, prevents the inadvertent intraoperative uncontrolled rupture of the aneurysm. Here, let's move to the surgical plan. Finally, the dissection that needs to be done in these cases. So as you can see, before, as we had already discussed, there's a 7-step strategy to it. So before draining the subfrontal CSF, we open up the lateral sylvian fissure. Here, if you can see, the brain is still full, and the pressure of the CSF is stretching the veins away from each other. Whereas if the CSF is fully drained, then these veins get crowded up, and we often find that in that condition, the dissection becomes a little bit messy, especially with all the blood in the CSF, which is already there. So we begin by the trans-sylvian route, opening up the lateral sylvian fissure. The idea is to reach the ipsilateral ICA bifurcation to trace the ipsilateral A1, then identify and mark the temporary clipping site. That's, we are identifying the A1 over here and trying to identify, seeing to it that if needed, we can put in a temporary clip on the A1 ipsilateral. Then through the subfrontal approach, we try to release the frontoorbital attachments and expose the interhemispheric fissure. Then some gyrus rectus is being removed. We trace the opposite A1 and mark the site for its temporary clipping. Trace the A2s in the interhemispheric fissure, and finally dissect the aneurysm. As you can see over here, we have dissected the aneurysm. The dome was going posterior superiorly, and the clipping had to be done in this manner so that you don't rupture the aneurysm. Now I'll show you only a couple of cases. This is an antero-inferiorly projecting multilobulated aneurysm. Again, through the trans-sylvian route, reaching the ipsilateral A1, first the ICA, then tracing the ICA to reach the ipsilateral A1, Once that is done, trying to find out the contralateral A1, there's the contralateral A1, ipsilateral A1. And now we can see the dome is stuck to the optic apparatus. It's stuck to the optic nerves on both sides and probably anterior portion of the chiasm. So gradually, without much traction over it, we try to dissect the neck. Once we have dissected the neck, we put a clip over there, and now only the dome is dissected out. Once the dome is dissected out, you check out for the positioning of your clip, whether adequate clipping has been done. And once we are sure that adequate clipping has been done, we do an ICG and can see that the aneurysm, all the three domes have been clipped successfully. This is a case of an anterolaterally projecting aneurysm. Again, the fork is open from the right side. That's why the right craniotomy, even when the dome is projecting towards the right side, we are still going from the right side because it's a big aneurysm and the dome is open on that side. Now, in this case, we had to be a bit careful, very slow and gentle in taking out the gyrus rectus. But ultimately, once the gyrus rectus is gradually coming out, and we put in a temporary clip on ipsilateral and contralateral A2s, A1s, as you can see. And now we are dissecting out, and we are seeing perforators, which will have remodeling of the aneurysm. I learned this technique from Misra sir while I was with him. How to remodel an aneurysm, how to remodel an AVM, he taught us. So this is how we approach it. And as you can see, using an arachnoid knife, a makeshift arachnoid knife, rather, I would say, the aneurysm is being remodeled. The perforators have been dissected out, and finally we can put the clip. And once the clip has been put, the positioning is reconfirmed, and an ICG is done, which shows that we could completely clip it. And finally, a word about the suprabro mini craniotomy approach. Now, this was done for an unruptured aneurysm. If you look at the CT angiogram of this patient, you can see the A1 on the right side is so rudimentary, as if it is not seen. And we were quite sure that we were thinking that a very thin A1 would be seen in this case on the right side. The left side A1 is obviously quite big. That's the ICA coming, bifurcating into MCA and A1. And that's the aneurysm. This was an unruptured ACOM artery aneurysm. So we used the suprabro mini craniotomy approach. Here you can see for the suprabro approach, the SOCA approach, we do not use much extension. That's the corridor being used, no retractor being used, and there one can see the aneurysm. If you carefully look over here, the aneurysm here also is stuck to the junction of the left optic nerve and the optic chiasm, and gradually, slowly and slowly dissecting out, trying to reach the ipsilateral A1. And there we realized that this actually had only a single A1. The right side was, the left side was not seen. So as you can see, the thinning, we have already put a temporary clip. And one can see carefully, if you observe, there is a slushing of the blood. The turbulence of the blood was seen. Finally, an angled clip has been placed, and the aneurysm could be clipped through the suprabro mini approach. That's the aneurysm which was clipped. So I think I finished in time. Thank you.
Thank you very much for a wonderful talk and description about various approaches and how to select the approach. That is the basic dilemma most of the time while selecting the approach. And this inferiorly projecting aneurysm, these aneurysms are very prone to rupture, and they are known to rupture. And posterior one is little difficult because just a lot of perforators are there. I would like to ask Dr. Misra sir and Dr. Kachara sir for their opinion.
Rajnish, go ahead. Rajnish, you can go ahead. I'll talk.
Listen to you, sir.
बात करो ना, बोलो फिर बात करते हैं.
Usually we approach from the side of dominant A1 actually, what we have learned and we are doing practicing it is okay. But many of the books And many surgeons, they prefer from non-dominant hemisphere, whether A1 is dominant on that side or it is hypoplastic. Some people, they prefer always from the right side, non-dominant hemisphere. But that we have practiced in a very few cases. But I always go from the dominant A1 side to approach the aneurysm.
Should
Yeah.
I add something?
Yeah. Sorry, go ahead. Whosoever is doing.
I think some of the surgeons decide the approach. One thing is clear: the dominant A1, 1 point. Second is he's the surgeon, very good right-handed surgeon only. Some of the surgeons are very good right-handed only. Their left hand dexterity is not that good. Like me, I'm very poor at controlling anything from left hand. So I have got a tendency to do things from the right side. That can be one of the factors playing in the minds of the surgeons. But the first factor should be considered, that the dominant A1 for the younger surgeons should be approached, because intraoperative rupture will demean them and they will deteriorate their morale. So I would suggest to have a proximal control at the dominant side. Mishra sir, please.
Yeah, what Rajneesh said, actually, Dr. Sarno, if you have heard, he goes always from the right side every single time. I mean, he never goes from the, which is, I think, a little bit of dogma. I go preferably from the right side, except if the aneurysm is projecting anteriorly and the left side is dominant, then I would go from the left side. But all other aneurysms, I prefer to go from right side. Doesn't matter whether it is right is dominant, left is dominant, fundus is left, right. It's not, kind of something which changes my approach. But if it is the aneurysm fundus is projecting anteriorly, then the contralateral A1 getting access, is sometimes difficult if you're going from the wrong side. So that then I would decide for the dominant side, but otherwise I prefer the right sided approach. And I don't think Dr. Mathuria is there, because otherwise you would have already shouted at Adesh about the Sukha approach, something which. But you told that it is unruptured aneurysm, so that's okay.
Yes.
That's all right. But somehow, I mean, though I initially was very fascinated by this approach. I've done few cases initially when I came back from Perneski, but after that I never did aneurysm with the supraorbital approach, because I had one case which bled. This was ruptured aneurysm actually, so it bled, and we had tough time getting, though we got away with it. But I think the comfort level was not as much as if I were doing a tibial aneurysm. So I don't prefer doing a for unruptured aneurysm. But if you're comfortable, that's fine. I mean, that's okay. But I don't do it. But very well done, others. Very well. Unfortunately, the previous talk I couldn't hear properly. I could not finish my case before 7 o'clock, so I was a little late to join.
So there are two questions from participant.
Janan sir wants to ask something.
Raghav, yeah. Dr. Janan, please finish your.
Yeah, I want to clarify with the panelists, including Mishra sir and Dr. Sandeep Mohindra. How often do we actually look at the fork of A2 to decide the approach? I think more important than the fork of A2 is the lie of the ACOM and how much anteriorly you can get to the ACOM to get that plane of the neck of the aneurysm. Your comments, sir, Mr. Sir and Dr. Sandeep.
Well, actually, I do a little more subfrontal if it is a posteriorly directed aneurysm. And also I have the access, if people would have, Dr. Juha Harnesniemi, you would have heard about his surgeries and his approach. He doesn't even do a tibial, he just does a subfrontal approach. He just barely exposes the sylvian fissure to drain the CSF. He always relaxes, but he doesn't do a temporal connectum at all. I mean, there is no trigeminal at all. He's at a lateral subfrontal approach. He does it. So I do more for ACOM. I do more, except If it is posterior dilated, I want to have the temporal axis because I want to see from a lateral side. Dr. Sudhir, I think Sudhir was asking that. You were commenting on that about the fork?
A2 fork, yeah.
Yes,
Yeah.
sir.
Yeah, it doesn't actually see. It is always, it is comfortable if you're doing the same thing again and again and again. So you don't change very much your approach, then it is much more comfortable for you. But I think if the fork is important and critical, like both of you talked about, to find out both the A2s and of course the perforators are critical. So as a routine practice, most of the time at least, I try to open up the aneurysm after I clip it, and so that I see the aneurysm is gone, completely skilled, and also you can see better the all the branches coming out from the ACOM area, because having said everything, ACOM is a critical area. I mean, you screw up one perforator, the patient is gone, kind of. So it's very, very important. And I do a little more gyrus rectus than what others talked about. I would like to go a little more, kind of distal. I would like to expose the A2 also. It doesn't, I mean, few millimeters of, I take out a little more gyrus rectus on A2 so that I have a distal view. Beyond, after I clip, I want to see everything a little more.
I think it is very nice of Mishra sir to literally expose everything and every nooks and corners of the ACOM.
Yes.
I'm really glad sir focused on that particular point, that the minimally removing that part of gyrus rectus doesn't matter much, because you have to be comfortable and the catastrophe should not
Absolutely.
occur.
Patient
That's
has
the
to
most
Dr.
important.
Sandeep sir,
Yes.
you said that you would prefer to go in from the right side, even if it is not the dominant side. Is it?
No. For the
No?
dominant side, I'll take up the
Always.
dominant,
Okay.
dominant only.
All
If the
right.
dominant is the left side, which is commoner than the right side, so
Okay.
I'll go from the left side. But the surgeons themselves should be aware of it, that they are right-handed or the left-handed, and they can have dexterity control more
Yeah,
from the right
that's
side.
a very valid point actually, because some of these aneurysms may require left-handed clipping also, because
Yes,
the lie of the
yes.
aneurysm neck
For
may
the
be
for
there.
the fork part, my contention is type one. Say simple type is the ACOM aneurysm projecting anteriorly and both the A2s are behind. Simple type one. Type two is both the A2s are open and the aneurysm is within it. Type two, and the whole A1 A2 H is there and the aneurysm is just lying below it. Type three. So in all these three categories, the best one is the type one, in which you just have both the A2s behind it. So this part is usually visible during your CT angios in the lateral films. So on that reading of that CT angio, I plan about the clipping part. Whenever I am dissecting the neck of the aneurysm, I'm well aware that both the A2s are going to be behind the aneurysm, and such an aneurysm, if I'm doing from the right side, is of the easiest and the fastest to do, as compared to the uh, type 2 aneurysm, in which the both the A2s are splayed up open and the aneurysm is within it.
Agreed.
Sometimes I use also a fenestrated clip for,
Yes,
kind of the first,
yes,
at least the tentative clip we put it, so that then you open it up and then or you coagulate, reduce the aneurysm.
yes, sir.
And then you see everything. Sometimes the fenestration may not be complete, so you put one more clip, but you put the tentative clip, then you can coagulate, open it up. And what Professor Yasser Gill is very, very fond of, coagulating and reducing the aneurysm.
Yes.
People, if you have seen his videos, every single case, in fact, my first, I'll just take 1 minute because this is historical. 1986, Professor Yasser Gill was the honored guest at CNS meeting, and that was my first meeting to US for an American meeting. And there is an American team had gone 1 year. They had spent to in Yasser Gill's department to do all the his surgery in 3D, and he was the honored guest. As you know, CNS has an honored guest. He was the honored guest that time, and they were continuously playing that 3D videos. And he presented, and then he clipped. he coagulated and then took out the clip. And this is an unruptured aneurysm. He took out the clip. He said, "There's nothing to be done." And then this American guy, I can't remember who was coordinating that, but he got up. He said, "Don't do ever this. This only Asargil can do it because this is a dangerous technique." But he is fond of, and it's a good idea to coagulate, reduce the bulk so that you can see everything before you come out, because clipping is only one part of the aneurysm surgery.
I remember, sir, Dr. Yuha had come for one of the micro neurosurgery conferences. I think 2011, our Neurovascon at AIMS in New Delhi, and he would clip the aneurysm, then he would coagulate it, cut the dome almost by coagulating, and then take off the clip, and then play around and finally put the clip.
Yeah, that's the Asargil's technique. That is because that is what he used to do.
Yeah.
So there are some questions from participant, Dr. Raghav, question. So, is there any cases with visual disturbances if clip everts or sometimes irritate the chiasm or nerve?
I have never had that. The clip has never
Usually no.
produced a visual problem in my, at least. And theoretically, yes, probably put a
Theoretically,
bulky
yes.
clip.
Sir,
Yeah.
I went through the literature. It is given over there that sometimes your clip can compress a part of the optic nerve, and it can take a part of the optic nerve, leading on to the focal deficits in the vision. But theoretically, it is there. But we have not seen it. But we have seen the vision loss in 2 of our patients because of the vigorous dissection of ACOM complex from the optic nerve. Just bearing the complete optic nerve had led on to the vision loss in 2 of our patients. But whosoever will suffer such a complication, you just can't make out. We can just hope that bipolar should not be used in the proximity to the optic nerves. Rather, no coagulation should be used. Rather, cotton and dissection should be used. For sharp seizures, dissection should be used. That is all.
Yeah,
Sir,
I had 2 patients who presented with Terson syndrome, and gradually their vision improved. But I never encountered any patient due to clip and due to some compression, there is visual disturbances.
as
There are
Sandeep sir was telling, not to use the coagulations, very important, because inadvertently, sometime during dissection, a small vessel over the optic nerve may rupture and start bleeding. Never ever coagulate on that. Just put a small piece of Surgicel gel foam and just warm saline, put it, and in 2-3 minutes.
It stops.
It is stopped.
So other questions are from Dr. Pawan.
One, I just want to make one comment. Over the period of years, I mean, early days and now, or now means last maybe 10 years or so, the smallest clip you use, that's the best thing. And it is better to use multiple clips rather than one big clip.
Yes.
You know, something which I have learned over the period of time, and I think it's very useful that you use less metal there. And it is better to, you know, for example, if it's a multilobulated ACOM, I would do a fenestrated and then a straight or an angled, something like that, but not to try to put everything with one large clip.
Yes,
it's always better. That is something which I have learned, I think, which has helped me.
Yes, sir. Agreed. Surgeons should shun their egos in that they are taking out the complete whole aneurysm in a single clip, rather than use 2 clips and reconstruct the ACOM. Aneurysm surgery is more of a reconstruction of the parent vessel rather than clipping of the aneurysm.
The questions from Dr. Pawan and Dr. HKG. I think these questions already have been answered about A24. And Dr. Satya had one question. If it is codominant A1, how important it is to temporarily clip the opposite A1? Both
if it is a ruptured aneurysm and the patient is not having an atherosclerotic vessel, very wide A1s, it's a good practice to have temporary clip before you put the final clip, especially if it is a large aneurysm, very thin wall, like Ades showed this blood, you can see the blood circulating inside the aneurysm, very thin wall. It's a good idea, though, of course, one can use adenosine also, which we now very frequently use it. But if it is a very atherosclerotic vessel, avoiding the temporary clip is not a bad idea. But otherwise, it's a good idea to put temporary clip.
Sir, on both A1s?
In both A1s, yes. If it is co-dominant, both are equally dominant, and it's a
Yes, sir.
ruptured complex aneurysm, large, multilobulated.
Okay.
I would put it, especially in young patient, yes.
Okay.
If elderly patients and if it's a very white this thing, then quite often I use very short, or I use one side and I use adenosine.
Okay, sir.
So before moving to next talk, just I would like to add one comment about supraorbital keyhole approach for aneurysm. This is wonderful approach regarding as far as exposure is concerned. Means it can be to some extent, even if there is some mild brain well, that also can be tackled with release of CSF. My only concern is about maneuverability of that clip applicator. That direction, there is no question about that. Bulge can be tackled to some extent. Cost message is excellent. My only concern is about that maneuverability of that clip applicator. That is little difficult majority of the time, I feel.
So I would like to answer that question. The most important thing is you have to be almost more than 90% sure as to which clip you will be using by thoroughly studying your CT angio. It should be almost decided as to which side, which size of the clip, which shape of the clip, and at which angle would you would use by cutting the bone in that area and then seeing through it. And second thing, use of your tube shaft instruments. You cannot use your conventional that Castravijos type of clip applicator. It has to be the tube shaft instrument. The only drawback with the Esculap's tube shaft is that unlike the Esculap's Castravijos, which has rotating head, the clip holders can rotate like this, so you can change the angles inside the clip. The tips also rotate like this for the Esculap Castravijos type, but for the tube shaft that does not happen. So with the tube shaft instruments, I think it can be done. So
There are some other questions as well, I think, but these questions will be covered in next talk. So now
share screen hai.
Hani, that I have done. Okay.
Yeah.
Yes, sir. Yes. Now it's
Now it is coming.
yes, sir. Yes, sir. Now it's coming.
Sure, that's.
Yeah, now it's seen very well. Sandeep.
Okay, sir. Okay, sir.
You start.
This one, sir. Okay, sir. Seen, sir.
Yes, sir. Yes, sir.
Okay. So I'll be discussing the complications during ACOM surgery. Quite a significant part has been already covered because the complications will always pertain to the anatomy if we misread it, and the surgical approach if we misapproach it somewhere this or that way. This slide will move next. Okay. So aneurysm surgery, the goal is mainly obliteration of the aneurysms, and the incidence of residual aneurysm varies from 1.8 to 3.6%, and the main aim is to preservation of parent vessels. Incidence of parent artery occlusion varies from 1.6 to 21%. So that is the major complication which we note, that even the parent vessels can get occluded by the placement of the clips. So, and the third point is the preservation of perforators and the branching vessels, which was covered so nicely in the first talk. The perforators and the branching vessels, and the placement of clips will show us that the parent vessels has been preserved or not. 21% incidence reported with the occlusion of the parent vessel is too much of a complication, and if it has been documented, that means we have to be aware of it. So now the disasters which we face in the aneurysm surgeries, it is not only pertaining only to the ACOM aneurysm. The most important, the most fearful complication with the aneurysm surgery is the premature rupture and the uncontrolled bleeding. Even that is okay till the brain itself swells on to the tremendous aspect, making the surgeon shiver himself to abandon the surgeries. The surgical strategies for the aneurysms, for the intraoperative rupture can be tamponade, suctioning, temporary clipping, pilot clipping of the rupture site. Pilot clipping of the rupture site is same as that of tentative clipping. Temporary circulatory arrest. Dr. Mishra had himself told that he has been using adenosine in normal situations nowadays. I have no experience with adenosine. We are preparing our anesthetist for this thing, but I have not used it. But the literature is quite strong about it to use adenosine for temporary circulatory arrest. So the chances of rupture increase with the complexity of the aneurysm and its morphology. The more is the complex morphology, like multilobulated, multidirectional, with the one wall of the aneurysm stuck with the parent vessel, like A2. If one wall of the aneurysm is incorporated within the A2, then it has got a higher chance of rupture. Rupture can occur during the initial exposure, actual dissection of the aneurysm, or during the clipping of the aneurysm. We define this thing as the type stage 1, stage 2, or stage 3. All these intraoperative rupture situations are controllable till unless and until the aneurysm ruptures during the craniotomy or even before the dural exposure itself. Different definitions have been given in the intraoperative rupture, but the most accepted one definition is the bleeding that interrupts and alters the sequence of microsurgical procedure and excluded the trivial leaks that are easily handled. So mark the words, trivial leaks have been excluded, which are easily handled by just putting a patty and a suction. Most authors define intraoperative rupture as any egress of blood from the aneurysm during the surgery. So causes of the intraoperative rupture. There are many reasons which have been determined. You may also pinpoint some of the reasons during your intraoperative complications which you face when you have been experiencing or doing the ACOM aneurysm surgery. But still, some majority of the times you will not find any prominent or peculiar causative reason behind the cause of intraoperative rupture. Hypertension is the most important risk factor. Intraoperative increase in the transmural pressure gradient, either due to high blood pressure or significant decrease in the intracranial pressure. That is usually brought down by the external ventricular drain. Sometimes the surgeon has to put to let the brain relax off. Perioperative hypertensive episodes can be observed during patient positioning, skull pin fixation, local anesthesia infiltration should be done, periosteal dissection, and dural opening. All these factors have been determined which lead on to the hypertensive episodes causing intraoperative rupture. Intracranial pressure is increased in most patients with subarachnoid hemorrhage. That is well understood. Sudden decrease in intracranial pressure may increase the transmural pressure. Rapid mannitol administration, hyperventilation prior to dural opening, and rapid CSF drainage by lumbar drains or ventriculostomy catheters, which surgeons might put. Application of Valsalva or PEEP, that may be the causative reasons. Common causes of rupture before the clip placement. Now, once you have reached the A1, you have dissected out temporary clip placement, this location is ready, and then the dissection at the neck of the aneurysm is being done. Use of blunt dissection. Aggressive brain retraction, which might pull up the ACOM aneurysm projected anteriorly, inferiorly between the interoptic space. Blind dissection around aneurysm using blunt probe. Sometimes people just try to probe around the aneurysm, which is a blunt thing. Blind insertion of clip blades. Younger surgeons usually tend to enthusiastically put the aneurysm clips too early, at a too early stage, leading on those clip blades penetrating through the neck of the aneurysm and creating a catastrophe. Aggressive aneurysm manipulation, fighting against the high target aneurysms. This is a lesson for the surgeons, younger surgeons, not to copy the senior legendary surgeons, how they manipulate and they fiddle around with the aneurysms, because the aneurysms have high targeticity within it. Inadequate temporary parent occlusion. It can also lead on to the intraoperative rupture. Common causes of intraoperative rupture during clip application is partial clipping. So the aneurysm neck is larger than what the surgeon was seeing from its angle, and some part is left. That partial clipping can be one that the neck has been left partially. Another can be there is atherosclerosis at the neck of the aneurysm to such a great extent that the clip is not fully occluding the aneurysm, the neck itself. Aneurysm dome is adherent to the surrounding brain, which I have seen a number of times that once you put a clip, dissect the aneurysm from around and then replace the clip. You will find that after you dissect the aneurysm fundus from surrounding brain and reposition the same clip at the same place, the bleeding will stop. Atherosclerotic plaque at the aneurysm neck can be a turning point for the whole surgery. It will not let the aneurysm blades, the clip blades, go snugly against them and occlude the aneurysm neck. So you might need another clip just distal to it to completely occlude it. Clip application parallel to the long axis of the parent vessel is paramount. That is what I was mentioning, that it is not the clipping of the aneurysm, rather it is the reconstruction of the ACOM itself. Always put a clip parallel to the ACOM, reconstructing the ACOM. Whatever the extra part of the vessel is there is an aneurysm, and you just have to exclude that abnormal part of the vessel, so-called aneurysm, from the circulation. So management of intraoperative rupture. If it all happens, first, it is avoidable. Try to avoid as much as it is possible. If it is avoidable, well and good. But there is no aneurysm surgeon who has not faced it. Intraoperative rupture, it is potentially avoidable, but nonetheless occurs in some cases and must be managed successfully to achieve good results. That is there. Steps to avoid IOR depend upon the stage of the operation or phase of dissection and aneurysm location and configuration. It is divided into three parts. During exposure, dissection without proximal control, and dissection after temporary proximal control you have attained. So, if the intraoperative rupture occurs during the exposure, uncommon, it is noted only in 10% of the cases, associated with extremely poor outcomes because you don't have any proximal control and the whole brain is likely to swell up. Inadequate anesthesia during intubation is usually the cause. Pin placement can lead on to the blood pressure variations, leading into the intraoperative rupture. Excessive use of drill vibrations and removal of the lesser sphenoid wing can transmit vibration to the aneurysm dome. These are all hypothetical things which have been determined, leading on to the IOR during exposure, but nonetheless, the exact cause cannot be pinpointed. Excessive drainage of CSF may change the transmural pressure, leading on to the rupture. Aggressive early retraction on the lobe attached to the dome of the aneurysms. Limited options are available for the surgeon during this phase. Reduce the hemorrhage, clear the surgical field to allow rapid dissection of the aneurysm. The aim should be to gain proximal vascular control and cessation of tangential hemorrhage to allow micro dissection of the neck and clip application. And sometimes, if you do not have a proximal control and the bulging frontal lobe, you need to do even the subfrontal lobectomy to reach on the internal carotid artery and A1. Anesthetic management of IOR. Now the anesthesia people have got a different role to do. Rupture before the dural opening, ICP reduction, hyperventilation, hypothermia, 20% reduction in the blood pressure from baseline. Rupture after dural opening. Now open dura may accommodate obviously the most pathological swollen brain rather than the closed one. Hemodynamic management is needed, blood pressure reduction is needed, hypothermia and neuroprotection, which has been advocated and is mentioned in the literature. The second stage is intraoperative rupture during dissection without proximal control. Operators completely understanding the relevant vascular anatomy. Wide opening of the Sylvian fissure by sharp dissection drains the cellular CSF from the cisterns, relaxes the brain, reduces or eliminates the need for fixed retractors, and further reduces the risk of IOR. 75% of intraoperative ruptures occurred because of blunt as compared to sharp dissections. So this is the most important thing. Most of the damage is done because of the calm. The surgeon should remain calm, in control, and execute calculated and deliberate maneuvers. Use 2 suctions to clear the field. I think most of the surgeons must be using 2 suction hose pipes, these catheters. In all the aneurysm surgeries, we still use 2 suctions simultaneously, and the one is this complete powerful one, and the second one is the fully controlled one. Place a small piece of cotton on the point of bleeding and use the suction tip to apply gentle tamponade. A fixed retractor blade can be placed carefully over the cotton on the rupture site to create the tamponade effect. But be careful, it should not swell the brain. Avoid rushing to clip the aneurysm blindly. It can worsen the tear on the dome and avulse the surrounding structures because aneurysm itself is the abnormal vascular structure. If temporary clipping is possible, hypotension must be avoided and cerebral protection should be used. If temporary clips cannot be used, transient cardiac arrest with adenosine is strongly advocated. If you have got proximal control, then there is much less of a problem. 45% of the IORs occur only during the final clip placement. So during clip placement, I have already told you, avoid blunt dissection, temporary clipping to relax the aneurysm, avoid aggressive dissection of perforators while manipulating the aneurysms. After clip placement, once you are putting the permanent clip on the ACOM aneurysm, and there is an intraoperative rupture, inadequate neck dissection of the aneurysm has been done. That is for very clear. Partial clipping is there because of atherosclerosis, and your clip placement is not parallel to the parent vessel. I think it is not playing. I'll take up the videos in the end. I'll just skip it. So vessel occlusion, the third complication, the parent vessel gets occluded. Vessel gets occluded and completely compromised. That is because of the atheroma of the thrombus or the clips we have applied. They have taken up the complete parent vessel. Unexpected need for vessel occlusion, that has happened sometimes. Or if there is a fusiform or a Blisser aneurysm and we are trying to clip that, and the clip moves on to the parent vessel. Popular methods for avoiding vessel compromise: visual microscopic inspection, inaccurate up to 30% of the cases. Intraoperative angiography is invasive, time-consuming, and cost. Microvascular Doppler, yes, we used to use it earlier, but nowadays we are relying on ICG. Electrophysiological monitoring or dye angiography. So I'll just skip. This video is not playing. So this one is a nice photograph showing ACOM aneurysm and an ICG, a clip placed, and all the things, parent A1, both the A2s are clearly visible and the clip has been placed. Preservation of perforators and branching vessels. Perforating arteries originating from ACOM and superior and posterior surfaces, as the demonstration already in the first presentation. It was very nicely done. Chiasm, hypothalamus, septal region, recurrent artery of Huebner, head of caudate nucleus putamen. All these things has already been covered. I'll move ahead. So this part has already been described. So brain swelling. Brain tightness is frequently encountered during opening of the skull. Diversion of CSF during using lumbar drain or ventricular tap may be required intraoperatively. Persistent brain swelling is related to the severity of SCH, both in terms of clinical grade and amount of extravasated blood. Brain resection may be necessary to control extracranial herniation at times if there is an intraoperative rupture just after the opening of the dura. Electrolyte disturbances may be one of the reasons behind the brain swelling, which may be noted, and the most common factor is the hyponatremia. Initially thought to be uniformly manifested as SIAD, it may be more commonly because of the cerebral salt wasting. These are the cognitive dysfunctions which have been noted. A classical one, ACOM syndrome, impaired memory, personality changes, confabulation, focal lesion in the basal forebrain. Delayed neurological deterioration has also been noted. Increased edema surrounding hepatomas, contusions, infarcts, rebleeding in the aneurysms or aneurysm remnant. The postoperative follow-up may show hydrocephalus requiring shunt placements. Infections including ventriculitis is noted. Hyponatremia is commonly encountered after ACOM aneurysm surgery, and it should be very well taken care of. Hypoxia and cerebral vasospasm, they are all part of all aneurysm surgeries. Cerebral vasospasm, they are all related to thick subarachnoid clots, type 3 subarachnoid hemorrhage, Fisher grade, intraventricular hematomas, persistent subarachnoid clot, and poor neurological condition on the admission itself, Hunt and Kosnick grading 4, and history of smoking, diabetes, and pre-existing hypertension. Management of vasospasm as such, you all know about it. This is the classical management. Triple H therapy, excluding the hypertension part. Nowadays, we are not hypervolemia part, which we are excluding nowadays. Normovolemia, hypertension, and vision loss. This question was pointed out just 30 minutes back. Vision loss. We have encountered 2 patients with vision loss. Manipulation of the optic nerve in microdissection. Optic neuropathy has been encountered. Optic nerve compressed by the clip requiring clip manipulation is mentioned in the literature, but we have not encountered this requiring the readjustment of the clips. Clip head is superior to the optic nerve usually, and when you relax it, the clip might go down and make compress upon the optic nerve. This is a theoretical possibility, but it is mentioned in the literature. As the retractor is removed, the anterior cerebral artery, ACOM, and the clips can be pushed anteriorly, leading onto the optic nerve compression. As mentioned in the literature, but we didn't see this. We have seen the first thing only, manipulation of the optic nerves with the microdissection, causing the optic neuropathy, which we have encountered. Sequelae following vascular injury may be immediate due to vascular injury during microdissection or delayed after an episode of vasospasm or hypotension. This might happen. Early recognition of vision loss post-surgery must be recognized early, and immediate re-exploration may be required for compressive optic neuropathy secondary to the compression due to the clip. Thank you.
Thank you very much, sir, for a wonderful talk on covering complications. So we have some questions. So questions from Vidya. Maximum temporary clip time.
Yes.
What should be the maximum temporary clip time?
What I do is I do not take the temporary clipping time beyond 3 minutes, and with the normotension maintained over there, but I do not place temporary clips on both the A1s. In a normal sized ACOM aneurysm, I placed temporary clip on the side of the approach A1 for not more than 3 minutes. If required, then I'll remove the clip, wait for 3-4 minutes to reperfuse the brain, and then again use the temporary clip.
And
Sir will answer. Dr. Madhurya sir is there. Sir?
Yes, yes, yes.
but,
Nice, Dr. Sandeep. Excellent presentation. And what he has told about the intraoperative rupture, I don't know whether he remembers or not. There was a patient of PCOM aneurysm, which he was trying to clip and it ruptured. We hardly had a small carotid in front of that. I admire his dexterity. He partially drilled the ACP at that time and attained the proximal control and then clipped the aneurysm. It's really nice. And since then, we have been always trying to see that how much is the proximal neck of the PCOM aneurysm from the anticlinoid process. So what all you have shown is excellent. And about the, say, the temporary clip, what you have been telling. Temporary clip, say, least you put, better it is.
Yes, sir.
But maybe about 4 minutes and then reperfusion time of 7 minutes. And when you are putting the temporary clip, tell your anesthetist to raise the blood pressure by 20. So the perfusion will be maintained better. That's what I used to practice. Then there are few comments about the other things. I was talking to Jayanand also, that as he has told that the perforators at the back of the ACOM, and the Professor Ghazi Asargil described the perforators are postero-inferior. Say when you are putting the patient in extension, the posterior perforator will go inferior and these will be like postero-inferior perforators. So that's how these are. And if Sandeep remembers, I think that is the area we used to be a bit skeptical because it might be supplying the hypothalamus also.
Yes, sir.
Yes, charger. So that is the other thing. And then the say about the Dr. Avdesh.
Adesh, sir.
One comment on that, please don't mind. See, the thing is that
mini craniotomy. Sir will comment on mini craniotomy.
No, not about that. Say my comment on that is always try to use the maximum zoom what you can. Many places I found that the zoom is less. So zoom should be, only you should be seeing the vessels and the aneurysm, a little part of the brain, nothing more than that.
Agree.
Okay, sir.
That's very important, because many a times what I used to find is, I used to talk to the say the JICE people, can you increase the zoom further? The zoom which is maximum, I found many a times it was less. So that is something which should be there all the
Sir.
time. Zoom up to the maximum possible. Then about the left-handed and right-handed surgeons, I think Sandeep will remember that.
Sir, we learned from you only. I
should
was very
try-
poor.
No, you should try and improve the dexterity in your left hand.
Sir, I'm trying for the past 10 years. It is not improving.
It will improve. It
Extremely
will improve.
difficult, sir.
And the other thing is, always try and use the foot control of the microscope. So at the time of temporary clip, when you are using the hand control, you are wasting 15 seconds at one time, which is not fair. Then in the temporary clip, when you are putting a tentative clip, what I say is, when you are putting a tentative clip and you are not dissected the aneurysm fully, you put a tentative temporary clip. So even if a vessel is occluded in the temporary clip, it will not be crushed. That is one thing which you can do more. And I appreciate telling about the frontal lobectomy. Say, if
Sir,
the
it
brain
happens
is
sometimes.
full, it's really good.
Yes.
This I learned
no
from
good way.
Professor. This I learned from Professor Matthew Chandy. I had this thing with when I was doing a ECOM aneurysm in Muscat. Professor Matthew Chandy was there. He told, just chop off the temporal frontal lobe and go straight to the vessel. That is something very good. It should be done, because anyway you have to approach.
Lose the patient. Anyway, we are losing the patient, sir.
That is very important. And you can approach all the aneurysms from the right side. That is no problem. But the antero-inferiorly directed aneurysm, never approach from the contralateral side, which Basant has already told you. Because the reason is, many a times it is stuck to the anterior frontal dura. Then it will be a problem. And Sandeep will remember that never ever put a retractor on the frontal lobe till you have defined the A1
Even,
for
yes.
the antero-inferior projecting aneurysms.
Yes, sir.
That is something which has to be there. And sometimes if there is a rent at the close to the neck, what you can do is that you can put a cotton on that and put a clip on that. It is a clip on the wrap. That also you must have seen, and we have put
Yes,
many
sir.
times. But
Yes,
what you have to do is, you try to raise the blood pressure to the maximum level which you are going to raise in the post-operative period. Otherwise, the clip will blow off. And blowing off the clip, among say 25 patients, I put those clips. But 2 patients, the clip blew off, and those patients died also. So that is one thing which that is the last thing which you have to do. And the biggest thing is, when there is an intraoperative rupture, you must have an excellent assistant who can suck out and provide an absolutely clean field for you. That is very important. And what to talk of 2 suctions, Sandeep, you should have 3 suctions. It should be there. I think that is enough. And about the subfrontal craniotomy or SOCA approach, there are people who are really doing it now. I appreciate that part. But only thing is that, as he has already told, it's really difficult about manipulating the instruments. That is something which is difficult. And many a times you are unable to decide that which clip you are going to put and which direction you are going to put. So in that direction, whether you will be able to manipulate the clip applicator or not, that will be a problem. Otherwise, I am not. I was against it. Basant was absolutely correct in telling this. But gradually, the people are picking it up, and they are doing a good job. So you should learn that technique.
Thank you very much, sir. There are some questions as well. Dr. Raghav is asking, what do you use for vasospasm apart for papaverine, intraoperative papaverine use?
I use only papaverine intraoperatively, warm saline, and nothing else. No, nothing more than that. in post-operative period, if the patients show these signs and symptoms of vasospasm, we go in for DSA and nimodipine infusions
Many
by
a times what
the
happens
radiologist.
that you
Sir?
can give say we are giving you can give this milrinone infusions also,
Yes.
because
Sir,
the endovascular people have used milrinone
They use very
intraarterial,
frequently.
but there they have found lot of hypotension.
Hmm.
And but subsequently, when I was talking to Vivek, he told that subsequently they have put it in that, and the hypotension thing was not much. But the say how many times you are going to put the intra-arterial milrinone or intra-arterial nimodipine. So you can give say the milrinone infusion, that is also quite effective. And sometimes I think we had been doing lumbar drainage of the CSF containing blood. That
Sir,
also will be very good.
nowadays, sir, we are not doing it because of this fear of meningitis, number one issues. And sir, if for DSA and nimodipine infusion, what we do is, if DSA and nimodipine is decided for a patient, the patient is shifted to DSA, and that catheter is left placed with the
No, I
patient.
know that. I know. We had been doing that earlier.
Haan ji, sir.
One thing about when you are putting a EVD or
Haan ji,
you
sir.
are putting in a shunt,
Ji,
and the
sir.
patient is and the ICP falls and the cerebral perfusion rises and the aneurysm ruptures. About that, I am grateful to Dr. V.S. Mehta who told me this. I told him sometimes this thing. He told that what you put a high pressure shunt. So sometimes what you can do is, when you are putting a EVD, make this high pressure shunt as a EVD and then drain. So it will not drain much. It will drain only when the ICP is rising, so the aneurysm will not rupture.
Controlled CSF drainage.
Yes,
sir,
yes, it will be a controlled CSF.
Yes, sir.
I think I spoke a lot, and now you speak about it. And
Next question.
Sandeep,
Sir.
I have one question.
Sir.
Have you heard any hypothalamic post-operative hypothalamic disturbances, particularly in massive subarachnoid hemorrhage patient you have clipped, and they develop severe hyperthermia and
Yes,
all
sir.
this kind of
Yes, sir.
lose patients?
Yes, sir. We have seen patients like this.
The one of
But
yeah.
This complication is related not only to the particular ACOM aneurysms, but in a diffuse subarachnoid hemorrhage at the skull base. And for example, like internal IC aneurysms projecting medially, IC aneurysm projecting
Particularly
medially.
ACOM aneurysms.
ACOM aneurysm, yes.
Particularly
Even
ACOM
IC
aneurysms.
aneurysms projecting medially with a thick subarachnoid blood at the just against the lamina terminalis, what we see, and the septum pellucidum, you will find patients with hypothalamic dysfunctions. I have seen, and we have recorded all these complications, sir.
No, sometimes you lose patients actually.
Yes, sir.
Patient
Yes.
can
With
the
the
temperature
fever of
can go up to 107, 108.
Yes, sir. 106, 108 degrees, just like a craniopharyngioma surgery complication.
Right.
It has happened, sir. But this complication is related not to our clipping, surgical clipping. It is related to the ACOM aneurysm lead itself.
Say, when we are telling that surgical clipping or not surgical clipping, it is what is the outcome of the disease which you are dealing with.
Yes, sir. That means hypothalamic complication leading on to fatality is recorded, and it is there.
Yes, yes, it is there. हेलो
हेलो कैन आई
हाँ अनिल तुम्हारी आवाज नहीं आ रही थी
Anil, unmute.
Yes, sir. Yes.
and Dr. Tripathi, can I ask one question to Dr. Sandeep?
Yes, sir. Yes, sir.
You know, what we have been taught that ICTOS day 3 to day 10 you don't operate, depending upon the fissure grade and clinical grade. You know, many a times there is thick subarachnoid hemorrhage as far as a fissure grade is concerned, but on day ICTOS the patient is still conscious. WHO grade 1. What we will do? I have a bitter experience. I operated one patient, clip, hoping that it is WHO grade 1. and grade 2 fissures, grade 2 SH. And patients of post-op, he had multiple infarcts. On
Yes,
the
sir.
other side, one more case, on the 7th day of ictus, there is subarachnoid hemorrhage, fissures grade 2, WHO grade 1, operated, and patient improved. There is no infarct. So, is there any other method to decide what to do, when to do, when to go for clipping, when to not to go for clipping, or is still fissures grade and WHO grade is the deciding factor?
Sir, at our center, we are deciding purely on the basis of WFNS and Huntington's grading only, not the timing. As soon as the patient comes, if the patient is in grade 3 or above, better than that, the patient will be taken up for surgery. If the patient is not conscious and with SAH and not a blood thick clot, no, we don't have any other factor like ICH, like temporal ICH or frontal ICH, that patient is held up for surgery till the patient improves. But the post-ictal day is not the determinant factor to take up the patient for a surgical clipping, at our center at least. Because if you have delayed the surgery till 7th day of taking up the surgery, just for the fear of preventing infarcts, we are exposing that particular patient to the risk of rebleed of the aneurysm also for those 7 days. In those 7 days, the risk of rebleed is also the highest.
Okay, any other comment from Professor Mathuria?
Actually,
Basul,
when the patient is improving, the perfusion is improving. The perfusion to the aneurysm also is improving. That is what is leading to the problem, Pradipta. Actually, the thing is that as Sandeep has told, if it is grade 3 or better, no time, rather from Amritsar, somebody will call and say that, sir, I have seen a patient has got a subarachnoid hemorrhage, he has got a ACOM aneurysm, he is coming to you, reaching you in 5 hours, so the OT is ready in 8 hours. So it should be like that. If it is during the time we are able to clip before 9 p.m. or we are able to clip after 7 a.m., then it is fine. So that's the way it should be. And the otherwise, if there are poor grade patients or in patients in whom we decide that we are not going to operate, then we subject them to endovascular techniques. So now we have got, I think, Sandeep, we have got all the endovascular support. There is
Yes,
no
sir.
problem with that.
Yes.
And to the extent that the endovascular patients after endovascular techniques are kept in neuro ICU only.
Yes, sir.
So the patients are, say, managed by us. So all this, Pradipta, this waiting on a patient, it's really difficult. Because the reason is that many times you lose the patient.
why my question is that in the first case, he came on the 5th day, I operated on 6th day, 7th day he had infarct. And the next week, a patient come in the same 4th day, and there is subarachnoid hemorrhage. I planned for surgery, but there was a fear. He may land in a last case. So I didn't do this surgery. That is my question. Is there any other criteria?
I will tell you one thing, Pradipta. There is one thing more which you can do is you can try and find and see the TCD. You can try and find how the vessels are looking like at CT angio. What is the perfusion like at the time? What is the age of the patient? What is the grade? How thick is the clot? Whether the thick clot is in the is it a ICH or it is a intracisternal bleed? These all things should be taken in consideration, and then you should operate. I think, say, the waiting is going to create a problem, because the reason is, say, I'll just take 1 minute more. There was a patient in whom we did an angiogram. The patient did not show an aneurysm. Sandeep, if you scratch your head, you will be able to remember that. Then after that, we did a DSA. Did not show the aneurysm. But as per the history and as per the location of the bleed, patient should have had an aneurysm. We wanted to do the DSA after 5 days. The patient rebled on 3rd day and died. And 3rd day when we did the DSA, it showed the aneurysm, which we missed on the DSA and CT angio. So the dictum which we have made after that is, as soon as the patient starts improving a little, just do the DSA at the time. Don't wait for 3 or 5 days. So don't wait. If the patient is good, great, operate. That infarct patient might have had many other problems. It's not because of the day that he had the problems.
Okay. Thank you, sir.
Thank you, sir. Thank you very much, sir. We have some questions as well, sir. This Dr. Ninad has shared his experience. He has written, I had a patient with ruptured ACOM aneurysm who presented with headache and 3, 4, 6, and 7th cranial paresis, more on right side. And paresis improved on its own over a period of 3 weeks. So he has requested opinion about.
No, I couldn't follow. What you are telling, there is a patient.
So there was ruptured ACOM aneurysm who presented with headache and 3, 4, 6, 7th cranial paresis, more on right side. And that paresis improved on its own over a period of 3 weeks. So he has requested opinion about this. Means what would have happened is why on one side and why there was paresis on multiple cranial nerve.
3rd, 4th, 6th, and 7th.
Yes, sir. Yes, sir.
Strange.
7th nerve, I had twice in some of the patients.
7th is UMN or LMN?
So that he has not mentioned, sir, actually.
Elements.
Who is can you tell him to give him my number? I'll talk to him and then think about it, how it is, because I'll try to gather more details from him. Because what you are telling that with the ACOM aneurysm, getting this and getting a LMN facial is extremely difficult. Might be that we are missing something. So that's the thing which I want to ask him.
Yeah, without seeing his scan, it's difficult to.
Yes, we need to see the CT scan.
CT scan, and I speak to him that how is the thing going on and how all these things happen. So it's no problem, definitely.
Yes,
I'm
sir.
there any day, anytime, no problem.
And Dr. Sikhil has asked any role of IV nimodipine after surgery.
IV nimodipine, Sandeep used to give a lot, and I used to tell that why you are giving.
Yes,
Because
sir.
the
It is of no use.
Oral
nimodipine is much more
according
effective.
to me, oral nimodipine is
It is-
as good as IV nimodipine.
Yes, sir.
And if you have to give nimodipine, any parenteral, then it should be intraarterial.
Intraarterial, yes, sir. Intravascular nimodipine has got, intravenous has got no role.
No role. The the oral nimodipine also, sometimes what happens, we are giving it 60 milligram 4 hourly.
Yes, sir.
Sometimes the BP falls.
Yes,
If
sir.
the BP falls, you raise the blood pressure by vasopressors for some time, and then still give nimodipine. But if the BP is falling, then what you do is you can give it even 30 milligram 4 hourly. Once I was speaking to Dr. Rajsekhar, he told me that our dose is 60 milligram 4 hourly, but the efficiency is quite a lot with 30 milligram 4 hourly.
Yes, sir.
So you can do that as well. Because the maintaining the high blood pressure is prime, and then is the nimodipine. And nimodipine oral is good enough. That is no
It's
problem.
good enough. Agreed, sir.
Yes, sir.
Other question, Dr. Vikram is from Nepal. He has commented in general. Which grade of aneurysm SH bleed the clipping is suggested in prospect of optimal post-clipping outcome and recovery of financially constant patient?
No, I couldn't follow. Again, repeat the question.
Sir, he has asked which grade of aneurysm SH bleed the clipping is suggested in prospect of optimal post-clipping outcome in recovery of financial constant in financially poor patient.
Till grade 3 is okay.
Yes,
Till
sir.
grade 3 is okay. And if it is still grade 4, then what you should do is that try to improve the grade. And if the patient shows hydrocephalus, you can again put a high pressure shunt, and then you improve the grade. And once the grade improves, the grade 3 should be okay. Means that should be fine, because when you are asking about the clipping, obviously we are unable to do the endovascular thing because you are putting the financial thing also
Yes, sir.
on that.
So he is particularly
there
asking about financial
it
issues.
should be about that. So it can be done like that.
1, 2, 3 grade only.
1, 2, 3, yes.
Yes.
After that, improve the grade.
Only
Make
that.
all the attempts to improve the grade, and then say recently something had come that if there is a patient who is in the periphery and you have to delay the surgery for a few hours, then I don't know whether it is correct or wrong, but the few articles have come up that you can give epsilon aminocaproic acid also So it will bring down, reduce the rebleed time for some time, and then the patient can be transferred to the proper center. But to be very frank, we have not been doing this, so I don't agree to that much. But there are few studies which has come up. This is only few hours you are buying that when the patient is going to a proper center. Otherwise, for that Nepal Vikram question is this only. That's all.
And there is one more question from Parth. How to manage autonomic dysfunction post clipping? Is there any role of clonazepam or other medications?
Sandeep, बताइए कुछ, मुझे नहीं पता है.
I think post ACOM aneurysm surgery, autonomic disturbances are noted. There's no doubt about it. But you need to maintain the blood pressure with the cardiotonic drugs and maintain it till the patient gets rehabilitated to 3 weeks to 4 weeks time. After that, the reflexes come back on their own and the patient is good enough. You will not needing those cardiotonics later on. But during the initial part of ACOM aneurysm surgery, you will find that the moment you taper off the dopamine, the blood pressure goes down. This is because the autonomic control has ceased off because of the subarachnoid hemorrhage in the perimesencephalic cisterns and the hypothalamic regions. The management is your patient is conscious, good outcome, good conscious is there, obeying commands. You just maintain the perfusion with the use of dopamine till 140 to 140 by 90 with a good pulse rate and maintain it for over a span of 3 to 4 weeks. After that, then try to taper off the cardiotonics and the patient should be okay. Sir.
Yeah, I think all questions has been answered now. So it's time to wrap up. So
Only thank you, Anil. Keep it up, and to all of you. And if I have pointed out something which are not liked by you people, then
no, sir,
sorry for that. But
Nothing like that, sir.
But only thing is that my being in this webinar on invitation of Anil is no use if you people do not improve your dexterity in the left hand.
Sir, मेरे को कह रहे हैं.
The dexterity, how to improve the dexterity, give me a call. I'll tell you 10 ways to do it.
Okay, sir.
Sir has told to do shaving from the left hand.
हाँ तो करता है तू या नहीं? अभी शेविंग ही नहीं किया तुमने, इसीलिए. ब्रश भी लेफ्ट हैंड से करो.
ओके सर, ओके.
अब तो लेफ्ट हैंड से कटिंग के लिए ना आपको सीजर्स भी अलग तरह की आती है. दैट्स आल्सो अ प्रॉब्लम. बट anyway, you try and do these things. Yeah, you are young people there.
Okay, sir.
Okay. And no microscope used without foot control.
Yes, sir. Yes, sir. That's very important, sir.
Because say first time he will remember that when we had first Professor Gulati Memorial Oration, Professor Sano was the person who was going to deliver the oration, and he wrote that I want a foot control. सब ढूंढने लग गए वहां पे foot control. पहला जो हमारा माइक्रोस्कोप आया था, जो डॉक्टर काक ने खरीदवाया था 1981 में, उसका फुट कंट्रोल पड़ा हुआ था. तो हम नए माइक्रोस्कोप में लगाया, वो चलने लग गया, तो उससे हमारी इज्जत बच गई. तब से जो है हम फुट कंट्रोल बराबर यूज. It should be used. It will reduce if you are putting temporary clip 4 times. It will reduce your temporary clipping time by 1 minute.
Absolutely.
That's very important.
Thank you very much, sir. I would like to thank all the speakers. Mathuria sir, Basant Misra sir, he had to leave due to some emergency in between. Kachara sir and Dr. Pradeepta Tripathi sir. Dr. Manas sir could not join as some network issue. He is traveling and some network issues. And I would like to thank all participants. There was wonderful discussion and a lot of questions were raised from the participant. And I think we have tried to answer all these, address all these questions. And this webinar has been recorded. This YouTube link that will be shared very soon. So this initiative we have started, sir, and we will cover all the aspect of cerebrovascular pathologies in this. So next webinar will be announced very soon.
Oh, sure. Nice.
Thank you.
Thank you.
Keep it up.
Thank you.
Very nice.
Good. Thank you very much. Pradeepta sir is there?
Good night.
Yeah, I'm here.
Sir.
Pradeepta's shoulders, the Cerebrovascular Society is now. Huh?
It's only your blessing, sir. I am trying my best to keep the records and upgrade the members, whatever new things has come up, and how to proceed and how to learn this vascular surgery, which is almost, if you are a pure vascular surgeon, then endovascular things you feel little insecure, but that is nothing. That is
No,
nothing like
nothing.
that.
How
you
many?
have
I
to.
think we are still clipping 430 aneurysms
Yeah,
in PGI,
I know,
correct?
I know.
Yes,
So
sir.
that message should be given to the members that even if there are multiple societies and all, but still clipping holds good for certain why certain majority of aneurysms.
The
So that's the
one,
that is the
one,
aim of doing
yes,
webinars
yes.
and all these things to
One
keep
day I
the
was,
member.
one day I was in an international webinar where Professor Robert Spetzler was also there, and
Oh,
they
so
were talking
lucky.
about the clipping, coiling, and everything. Then I
Yeah.
told, that time I sent a message to Ashish Agarwal, my colleague, that
Yes,
how
sir.
many aneurysms we are clipping now. Then he wrote me
Yeah.
back that around 430 aneurysms we are clipping and around 100 aneurysms we are coiling every year. So that
Yeah.
message I gave, and the Dr. Robert Spetzler was like this. That's the
Yeah,
way.
I mean, you know how Dr. Robert Stelzner do the things. I mean, we all
Yes.
have been the opportunity to see how he clip the aneurysms and all these things.
ना
So
मैंने तो उनसे ये भी कहा, मैंने कहा भाई अगर आपको मान लो कि ऑपरेट करने को नहीं मिलते, सीखने को दिक्कत है, तो आप पीजीआई चंडीगढ़ चले जाओ, वो सिखा देंगे तो.
anyway, sir, thank you so much for joining us. Thank you, Professor BK Mishra, sir, and um, Anil should be applauded because of
Yes.
his effort
Right.
that being a EC member as well as the taking part responsibility of this webinar, and hope we will meet again very soon. Thank you very much to all my members. Thank you, Mahendra, for an excellent presentation. You are always ahead. Thank you.
Thank you, sir.
Thank you. Thank you very much, sir. Thank you. We'll very soon we'll announce next webinar.
Okay.
Okay.
Thank you. Thank you.
Let us close this. Okay.
Sir.